Sharon and I have known one another at least for 10 or 15 years, and uh, starting back in her work in Massachusetts. She's doing a lot of consulting these days. She's an expert in how to manage ourselves and manage our patients who are driving us crazy. And in this case, that would be our patients who self-injure. And I've been looking forward to this talk for the better part of 6 months, and hoping to get it going, and hoping that we could make the arrangements for this to happen today. So I've been really looking forward to this, and I hope that, Sharon, if you have uh, further introduction stuff to tell your audience, we should do it. And you have seemed to disappear, so I hope you haven't disappeared.
I
There
have
you
not
are.
disappeared. I am still here. I am
There you
still
are.
here.
And
Thank you, Mike.
I will not belabor this any further. We're past 2:30, and 2:30 my time, that is. And I invite you to just get started, Sharon. Thank you.
Perfect. I will. Thank you, Mike. Thank you for having me. And just a reminder, I know Mike said it before, there are folks that need to be muted. I think there's a lucky 21 and there's a phone number that starts 860. If you guys could just do a quick check and make sure that you're muted, that would just be helpful for everyone. Thanks so much. So I will get started. It's sort of, my plan was to be interactive, but I think the best way to kind of do that is for you folks to enter your thoughts in the chat. If there are questions that come up as I go along and you want to ask questions, I'll keep an eye on the chat. It's over on this screen. And if I stop to answer them, that's great. Otherwise, we can get to them at the end. So I'm just going to get started. So, before I get started, this is an intentional title, Supporting Behavior Change with Patients Who Self-Injure. For folks who self-injure, like any kind of problematic behavior, right? We can think substance use, we can think sex offending behavior, we can think violence. We, as clinicians, can't really do anything to folks to get them to change. We can support them as they decide to make change. And so I just want to be crystal clear about that. Because I think it's an important distinction to make. We can't make anyone do anything, but we can support people as they move towards change that they may want to make. So these learning objectives, we're going to talk about self-harm just kind of from the basics. We're going to look at how self-harm is supported, and that's kind of where we go into target change. We're also I'm going to challenge you a little bit to think about yourself in terms of your style clinically. And then I'll hopefully give you some practical tips. So before we get started, for some of us, I know for Mike, he's in Hawaii and it's 2:30. For me, it's 7:30 at night, which is usually past my sort of perky awake time. So I invite you all to take a deep breath with me, if you don't mind, in through your nose and out through your mouth. And I know you're at various stages of your day, but I hope that you can at least find some ability to focus and stay with us for the next few minutes while we chat about this. And I'm going to ask you to explore with me just for one moment, your whole self. So 100% of you, your entire being. Think about when you can be that person. Usually you can be that person, maybe with one or two other people in your life. Right? There's one or two special human beings with whom you don't have to be anything. If you're sad, you're sad. If you're angry, you're angry. If you're happy, you're happy. If you feel like something, you say it. If you don't want to talk, you can be silent. So there's someone around whom you can kind of be your whole self. So I just want you to kind of think about that for a minute. Think about how that feels to just not have to put on any airs or any other persona, that you can just kind of be yourself and what that feels like and how wonderful that is. And then I want you to think about when you go to work, what percentage of yourself are you bringing into work, right? Is it the majority? Do you kind of show up as 80% of yourself? Or is there just like this 20% of yourself work person and you kind of keep the other parts of you absent? So just kind of think about that. I don't necessarily need you to put that in the chat. It's probably personal. And then think about why you don't. I mean, I think in some ways there are practical reasons that we don't show up as 100% of ourselves, right? There are professional selves that we need to be in the workplace. And so we don't bring our PJ selves to work. But just kind of why? Why do you leave certain parts out of who you are when you're at work? And then I want you to think about the last time you sat with a patient or a client or someone in the professional space that you're in, and think about how much of yourself did you bring to that interaction? How much did you actually engage? Like, did you kind of connect with and engage with that person that you were meeting with? And then also think about if you see multiple clients or multiple patients, who are the easiest folks for you to work with? Are there certain characteristics of people that make them easier for you to connect with, for you to feel safe and comfortable with? Michael Niki, if you could mute out, that would be wonderful. I just saw your name pop up. And then, oh, maybe not. And then, thanks. And then the other question is kind of who's the most challenging for you? What folks kind of stir up for you, kind of bristly feelings? So again, just for you to kind of think about that. And then think about our patients. So especially for those of us who go in and out of prisons, imagine our incarcerated patients. They wake up in the morning. How much of themselves, they too have a whole self. They too have this kind of multifaceted way of being in the world. How much when they wake up in the morning, are they bringing to that correctional setting? I imagine it's really small, right? I imagine that there's a whole lot of themselves that aren't allowed to kind of show up in that space. And then within that kind of smaller who they are, how much of themselves do they bring into our clinical spaces with us? So when our clients are walking in to see us or our patients are walking in to see us, how much of themselves are they bringing? Are we inviting more of the real person in the space with us? Are we inviting less? So just kind of thinking about that. And then lastly, that last question there is, what do we ask patients not to bring? Because I think, unfortunately, for many of us, there are things that we don't want to explore, we don't want to talk about, we don't want to hear about. And we're pretty good at making that known even non-verbally. So just, I'm asking all of those things because as we start talking about self-injury, I think it can be a complicated topic with lots of underpinnings of trauma and trust and a host of things that make it a very challenging thing to talk to our patients about. And if we're kind of setting up parameters about who they can and cannot be, what they can and cannot talk about, how much of themselves we do or don't want in the room, I think it becomes a more challenging thing to do. And I appreciate that everyone I'm speaking to is not a mental health clinician, but I think that it's valid even for those folks who are physicians kind of practicing in a different space than mental health. So I also want you to think about kind of how has your team been successful if you're working in a facility? How has your team been successful in addressing challenging behaviors like self-injury? And you can feel free to stick those in the chat if that's helpful. But just kind of when you think about folks who hurt themselves, where have you been successful? How have you been successful? Like what's worked in those spaces for you? And then similarly, what have been the challenges? I imagine that there are patients who have hurt themselves and that something has been done, probably some sort of team effort to get folks to change that behavior. And there are probably those other individuals that we just continue to struggle with. Like it seems like no matter what we do, we can't seem to get them on track, or they stay on track very briefly and then they're back to hurting themselves. So just kind of thinking through that stuff as we kind of move into this. So and I think if you take nothing else away today, I want you to take away the first statement on this slide, which is that self-injury is not the problem for the patient. In almost all of the situations where I can think of individuals that I've worked with who hurt themselves, self-injury is the patient's solution to a problem. They think it's the thing that's going to fix the problem. We think the self-injurious behavior is the problem. That is not true. in most cases. In most cases, self-injury is the tool that the patient is using to fix some other problem that's apparent for them. And in many cases, it works to solve that problem, or at least temporarily avoid that problem. For patients who self-injure more than once, for whom it's an ongoing event, it works. They wouldn't keep doing it if it didn't solve the problem, right? It's that we're all human, we're all animal, and we engage in things because the result that comes after that thing seems to be what we wanted. And so the self-injury is working for patients to kind of help them solve whatever problem is in front of them. So I also want you to think about in your own life, what do you think it would take for you to intentionally harm your physical self? To intentionally cut or burn or insert or swallow a battery? Where would you have to be? And I think when I think about that, things would have to have gone horribly wrong. My words are no longer working. I don't feel like anyone is hearing me, even if I'm using my words. I don't know who to go to. I don't know how to get help, right? Like feels like last resort to me. I would have to be in an awful, horrible place for me to think that hurting my physical self is the right answer to the current problem. So I imagine that for lots of our patients, that's also the case, right? They have just found themselves in this situation where I don't know what else to do here. Now, for some, over time, it becomes the go-to behavior because it worked at one point and I'm going to keep doing it because I want that reaction again, certainly. But in its initial form, right? At some point, somebody did this thing out of desperation, I imagine. Okay. So I just want to kind of hold that in our heads. And I have there kind of physically, where would you need to be? Emotionally, where would you need to be? Cognitively, where would you need to be? And just like spiritually, connection to larger meaning place. I mean, you'd have to be pretty disrupted to have that be your answer to your problem. So when we think about self-injury, we know that oftentimes self-injury is happening because of a trigger. Something either outside or inside is kind of causing a reaction. And because of that, folks engage in self-injury. So I have their emotions. We hear from folks who self-injure. Lots of times their emotions are intolerable. They don't want to have the emotions. They don't want to have kind of thoughts and memories. And so hurting themselves helps them kind of disconnect that, right? I can become more focused on the physical pain than the emotional pain. It can make the memory go away, right? So I'm having some kind of internal thing and hurting myself makes that go away. Also, folks with trauma history often, right? So things in the environment can trigger memories, things in the environment can trigger feelings. And so I'm going to hurt myself again to kind of make that, help that go away. Interpersonal conflict. I don't like what's happening between the two of us. I don't like this interaction. And so hurting myself can put a stop to that. Hurting myself can also bring you to me, right? For our patients who might feel alone. If I hurt myself, the nurses come. If I hurt myself, the doctors come, the psychologist comes. And so we can kind of have that interpersonal thing. It also can get people to get away from me, right? People can be repulsed by me. They'll stay away from me if I do this. It helps our patients escape. It helps our patients escape, as I said, kind of emotionally and cognitively. It also helps them escape in real life. I don't want to be here. I don't want to be in this housing unit. I don't want to be in this room with this cellmate. I don't hurt myself. You move me, right? I get out of here. So it also helps me kind of remove myself from either my internal state or my external environment. And then for other patients, we can also see drug-seeking behavior, right? If I engage in self-injury and that self-injury is painful, I may get some medicine as a result of that. Or I may be able to convince the doctor to give me some other psychotropic that I want more, right? Like I want Wellbutrin, I want Seroquel, and so give me those things because I'm going to keep hurting myself until you do. There are probably other reasons, but I think these are probably the primary ones, or the ones, at least for me, that we see most often in correctional settings. Sort of the ABCs of self-injury. When we think about self-injury from a behavioral standpoint, there are different ways we can think about it, but from a purely behavioral standpoint, any behavior that we engage in has these elements. I won't go in depth into them, but there's an antecedent, something that comes before, there's the behavior itself, and then there's a consequence. So the antecedents we talked about a minute ago, right? They're kind of the triggers. Then there's the behavior, the self-injury. And then there is what follows that self-injury. And that's an important thing to think about too, right? So both internally, again, if I hurt myself, maybe that the thoughts, the memories go away, the emotional pain goes away, but also what happens outside of me, the external consequences can also impact whether or not I choose to do that behavior again. And I also want to be clear that when we talk about external consequences, things that are reinforcing, things that when they happen, I'm more likely to engage in the behavior again, they come in two flavors. They can come in an addition. So drug seeking, I hurt myself, I get something, I get medicine. They can also be what we call a negative reinforcement. Something gets removed. Maybe I get removed from my noxious cellmate. I get removed from a dangerous situation. So it's not only that I add something, that can be a consequence, but also the removal of something can be a consequence that the patients find reinforcing. So just sort of keeping that in mind as we look at behavior. So when a patient has engaged in self-injury, the most important thing is what I said before. We need to try to understand, and possibly to help the patient understand, what's the problem? What are you trying to solve with this behavior? Now, I say help the patient because I think oftentimes they may not actually know. They know that hurting themselves has worked before. They know that something else changes and is different. Um, but they might not be entirely clear on what that is. So we need to kind of think that through with them. And the second thing I think that is the most helpful is talking with patients about alternatives to the self-injury, what they can do instead of self-injuring. Just asking people to stop doing things, we know from addiction treatment, we know from all sorts of things, is a really hard thing to do, to just kind of cold turkey stop a thing that you've relied on for a long time to help you feel better. So talking to patients about what possibly they could do instead of the self-injury. There are some treatment systems, for example, that substitute, right? Rubber bands on wrists, ice in hands. So things that cause kind of a physical sensation that can jar people, but at the same time don't cause the wounds or the scarring that we see with self-injury. That can work. For other folks, it's merely voice. Can you ask for the thing instead of showing me that you need it, right? Those kinds of things. So supporting patients around kind of alternative behaviors. And then our role in that is, how do we help them with those alternative behaviors? How do we support them? And I think this is an important piece because lots of times with patients who are working to change their behavior, they threaten self-injury. I'm going to hurt myself if you don't. I'm going to, right? And we feel controlled by that at times. We get annoyed by that at times. And kind of the correctional response is like, hell no, we're not going to give you something for threatening. However, depending on what we're working on with the patient, the words are better than the action. And so is there a way to kind of support the wording without necessarily kind of giving into the threat? And it's tricky, but I do think we need to evaluate as responders what we're reinforcing. Because when we fail to hear the word, we are almost asking for the behavior. And then we're surprised when it happens because they weren't going to hurt themselves anymore. But I think sometimes they're signaling to us in other ways, and we need to think about how we can respond to that in a way that supports reducing the self-injury. So one of the things that we can talk about is skill building. Again, probably not the role for a primary care physician, but potentially. What is it that our patients don't know how to do? Right? Do they not know how to assertively ask for something? Do they not know how to talk about emotion? Do they not know how to do a host of things, navigate a troubled relationship? And so some of it can be skill building. We can help them to learn what they need to do in order to not hurt themselves. If you learn how to ask, if you learn how to remove yourself, if you're finding yourself getting agitated, those kinds of things. Also kind of building in reinforcements. So can we be purposeful about saying, when you do X, patient, not self-injury, but when you do this other thing, you're going to get something, right? We're going to kind of reward that. And so is there a way to kind of put those trappings around alternative behavior? And then I think this we can all do. Can we work on decreasing the kind of rewards around self-injury? Can we work as a team? So lots of times, for example, I think about how much attention shows up during an incident of self-injury, right? How many uniformed folks, how many healthcare folks, we move patients, there's a lot of kind of upheaval and mayhem. And I know from talking to patients who self-injure, lots of times that's what it feels like inside of them, a lot of upheaval and a lot of disruption, and everything outside of them can be very calm. But when they self-injure, kind of the world matches their insides, and there's something validating about that. And it feels good to have everyone else feel as disordered and disorganized as I feel inside. So I think sometimes we need to acknowledge, can we decrease the response? There still needs to be a response. We still need to keep people safe. But can we be more measured and thoughtful about just how many people need to show up, and what does it look like when we do? And can we be kind of more caring and supportive in that showing up, rather than reactive and like controlling? Remember, behaviors that get rewarded, so behaviors that result in something positive, whether that's the addition of something or the removal of something, are more likely to reoccur. So things that kind of get rewarded, and I'm hearing someone else possibly on an iPad person, if you could mute, that would be brilliant. And we
I'll
think
fix
about
it.
behaviors, thanks, Mike. And we think about behaviors, especially in the same context. And what I mean by that is, if a patient can get out of restricted housing when they self-injure, because it works, then we're more likely to see self-harming behavior in restricted housing for that person, right? If this behavior I do is working for me in this place or in this relationship, then we're more likely to see that behavior. And over time, it becomes habitual. If you think about kind of go-to behaviors that you have that aren't necessarily useful, but they are things that you do. I think for many of us, for example, checking our phones, right? We've all become so fixated on our phones. We check them when we don't need to. And for some of us, we get a little anxious when we don't know where our phones are. So similarly, for patients who engage in self-injury as their go-to behavior, as the thing they do to decrease their anxiety, it becomes the way they kind of manage bad feelings. It becomes the way they manage bad situations. It becomes a habit almost. Again, especially in certain contexts, and especially when that behavior gets rewarded over time. So kind of thinking that through. And if you want to stick this in the chat, thinking about how your system where you are rewards self-injury. What good happens, what positive things, or what sort of removal of things happen with patients who engage in self-injury where you are? Oh, good, Mike. So you're asking about what happens when the system supports it. For example, if the patient doesn't want to actually go to trial. Oh, gotcha. So they avoid something, right? Fast. We will get there. So I think that I have touched on them. I'm not saying things pop up, but I think that I have touched on them. So patients get rewarded by relocation, by medicine, to Mike's point, by avoiding things they don't want to do, right? I don't have to go to that, right? Thank you, Alicia. Safe housing. I don't have to go to that trial I don't want to go to. I don't have to get transferred. I don't want to get transferred. I don't have to leave this inpatient setting. I want to stay here. Exactly. Sometimes it's just attention. See me, I am not invisible. People are noticing. Housing moves, lots of mayhem, all of those things. Perfect. And so I think that those are important things. And we have to remember also, reward is in the eye of the beholder, right? So for some of us, to have 27 people come running at us might actually be aversive. Like, I don't ever want that. And so that would not feel reinforcing to me. So I think sometimes we have to think about kind of, if the behavior continues to show up, then something rewarding is happening. And we sometimes have to be a little detective about it, because I don't know that it's always so clear to us what that reward might be. For example, I think restricted housing, there are patients who that feels safer to them to be in restricted housing. And so they may want to get moved to a room by themselves where no one bothers them for a while. So kind of thinking that exactly. So John said that, right? A single cell. I might want to be in a single cell. I might want to be on watch. My meds come to me, my food comes to me, right? That might feel just better than being out in population in a dorm. I got to go to Medline. I don't want to do any of those things. I want to kind of sit back and have the world kind of shrink for me, right? And right, a vacation from being in prison, right? For some folks to get out of the space, just to go, right? I get to go to a hospital. I remember a patient once telling me he was self-injuring quite a bit. And he said he would go, they would take him to the hospital, which was hours away, and he would refuse care when he got there, and then he would come back. And I said, why? What are you doing? Like, why are you refusing? You're demanding to go to the hospital and then you don't want the treatment. And it was Christmas time and he wanted to see the Christmas lights. Like, he wanted to get out. He just wanted to go see the Christmas lights. It made him feel like a person, to be out in the world and seeing the Christmas lights. Then he didn't really care about the medical care. And then he got to have the hours drive back. And my power, absolutely. There's some research out there that talks about social control around folks who engage in self-injury, and social control both ways, right? When I'm feeling controlled by my environment, one of the ways I can act out is violent. And when I don't always have the ability to act out violently towards other people, because I don't want those consequences, I can act out violently towards myself and gain some sense of autonomy and power back. So absolutely, positively. Some practical strategies. Keep an eye on the time. And okay, so practical strategies. Practical strategy number one is my favorite. It comes from the Dalai Lama. When you talk, you are only repeating what you already know. But if you listen, you may learn something new. So my sort of first practical step is stop talking. Let the patient tell you what's going on. Let the patient tell you. You don't need to correct them. Be curious about it. Ask more questions about it. Try to understand it. Give them space to tell you, even if it sounds ridiculous to you. Just let them talk. Let them tell you. I think that for many of our patients, they are so used to being told what they feel, probably since they were bitty. Someone else is telling them what they feel. Someone else is telling them what they think. Someone else is telling them how to be. And then especially in prison, right? Their worlds are controlled all the time. Can we just give them some room, kind of back to my opening? Can we invite them into the space and just say, like, the heck was that? And just let them tell us. And don't give them the words for it. I mean, I think lots of times I hear from patients who self-injure, like something another psychologist told them that I don't know is necessarily real for them, or something, a mental health or a medical person. You're hurting yourself to get attention. I hurt myself to get attention. Yeah, I'm not buying it. Talk to me, and kind of hearing it. So step number one, I think, is to just listen more than you talk, to see if you can kind of get at what's driving. The second thing is about our own style. We know comes from motivational interviewing work, but the idea that who we are with our patients helps to impact their ability to change and their thoughts about change. And the most important thing is what you see there. So non-possessive warmth. What does that mean? It's kind of unconditional positive regard, right? I am going to be warm and supportive towards you without any possessiveness about why, right? I am going to be warm toward you no matter who you are, no matter what you bring, and no matter the choices you make. And so kind of being clear about that there are no strings attached to my engaging with you. Being friendly, being genuine. So if things are upsetting, I know I am not a physician for a reason. I don't want bodily fluids anywhere near me. That was intentional for me. And that is true with my patients as well, right? And I have made that clear when I've been working with folks who self-injure for a very long time. If you're going to cut yourself, I'm out of here, because I want none of it. And that's genuine for me. I don't want to see it. I'm not staying here for that. I will get you care, but I'm out. And I think that that's just important because that's real. Respect for folks, unconditionally, we must always show respect. Affirming people, and that just kind of means supporting folks where they're at. I don't necessarily agree with what you're doing, but I understand it. I see it and I get it. It's not necessarily what I would want you to do. And then empathy, again, those things seem to be effective strategies in supporting people's decisions to change. What's less effective is aggressive confrontation, right? So you need to, and right, that kind of stuff, because as any of us know, when you get that, your first reaction is to push back, right? So if I push you, you're going to push me. That doesn't help anybody change. So we need to be, because I think lots of us do that, right? We want so badly for the behavior to stop that we like want to control folks. And we know from motivational interviewing, it's the least helpful thing, is to push. So keeping that in mind, kind of who we are in the room. Supporting change and shared goals. So it's very important to remember that motivation as a concept is not fixed. I am not a motivated person and you are not a motivated person, right? It's not like it's a thing that's ever present. Motivation waxes and wanes like anything else. It's not part of who we are. We all are motivated. Sometimes I'm not motivated other times. And when we're motivated, how we're motivated is an interaction effect, meaning it's dictated by lots of things, right? Whether or not I decide to eat healthy today, or go to the gym, or call my parents, or any of those things, there's a lot behind how come I may choose to or not to do those things. When we're talking about our patients, we influence our patients' motivation levels, right? We have an impact on that. They have an impact on our motivation levels. We know, as I said before, that empathic staff have better outcomes. So when we can try to understand where a patient is coming from through listening and watching and being curious, we are more likely to be able to help our patients. And then you see there that all change starts with no change, meaning everyone is where they're at. So everyone is at ground zero. And we have to kind of move forward towards something, but we're going to start at ground zero. So we have to be thoughtful about that our patients are where they are. And then the shared goals part of this has to do with, I think about it as, instead of sitting across from our patients, can we kind of stand next to our patients and look at the self-injury as the problem? So the patient isn't the issue, or whatever the problem is for the patient that they're trying to solve. Can we partner? So rather than being across from them, can we stand next to them, and together, can we tackle XYZ, right? I think that image is often really helpful for me, because and for our patients, I think it's helpful for them to see us as partners rather than kind of, I'm going to do to you, I'm going to make you, I'm going to talk to you. Can we together move towards something? And how can I help you do that? So thinking about that. So some of the clinical strategies, and I think this works for no matter the discipline. The first thing I have there is informing the larger team of the goals. So on the mental health side, if you are mental health, and you start identifying these goals for the patient, what they hope to achieve, kind of where they're moving toward. Lots of times it's a reduction in self-injury, or it's engaging in a different behavior, as I said before, an alternate behavior. And asking the patient's permission, can we tell lots of folks about this, right? So I think it's helpful when, and I'm sure it is for you folks on the medical side, when mental health is clear, like, hey, we're working with this patient on this thing, we're trying to support more words, we're trying to support more silence, whatever it may be. And we're all on the same page about that, so we can all kind of support the patient around the changes that they're trying to make. The second thing I have there is reinforcing approximate change. So again, it's really hard to just stop doing something altogether. So when I think about reductions in self-injury, reductions in frequency, reductions in severity, there are different ways where we can kind of see change, not entirely, the self-injury hasn't gone away, but it's less, or it's less severe, right? They didn't need stitches this time. So maybe we want to reinforce that. Hey, how'd that happen? How did you keep yourself from cutting more deeply, right? Those kinds of things, and reinforcing how that's a move in the positive direction. Expecting relapse and predicting it for the patient. Any of us who have ever tried to change a troubling behavior, if anyone's ever been trying to lose weight, you try to quit smoking, you try to decrease something or increase something else, we all trip and fall, right? None of us have ever perfectly made a change. Day one, I decide to do it and I never do that thing again. And so I think that it's really important to normalize that for patients and say, hey, look, no one's perfect, right? Permission to be human. You are going to slip and fall back on a behavior that you've relied on for a really long time. And when you do, we're going to pick you up, we're going to dust you off, we're going to keep you moving. And so kind of helping normalize the trips and falls, because they're going to happen, right? They happen for all of us. letting the patient borrow your hope and stability. I think sometimes just staying on the team of, I know you got this, and not in some sort of Pollyanna way, but just in the way of you're working really hard and change is really hard. And I have faith in you. I believe in you. And I know that you can get there. Just having that, because it's, again, for lots of our folks with the histories that they have, I don't know how much experience they've had of somebody in their corner saying, you got this. And so if we can kind of help our patients that way, I think that we can be enormously supportive. And then the last thing I have, again, this comes from the motivational interviewing language, is about amplifying ambivalence. Anytime any of us are trying to change, we're not always 100% sure that we want to make the change, right? There's kind of positives and negatives about change. And I think especially for ingrained behaviors like self-injury, I don't know that I want to stop, right? It works. All of these things happen when I hurt myself. I get all kinds of stuff. It's predictable. I know how to use it. I also think, for some of our patients, they become like the headline patient. Everybody knows their name or everyone fears their behavior. And there's some kind of like gratification about that, about being like the guy who can hurt themselves worse than anyone else and everybody knows me. There's some risk in losing that. And I have heard from lots of patients, especially folks who struggle with borderline personality disorder, when I stop hurting myself, you're not going to come around as much. I'm not going to see you as much, right? And there's some truth to that, right? Especially you think about like physical health doctors. So patients stop hurting themselves, they're not going to see you as much because they're not going to have occasion to. And we need to kind of amplify that, right? This is really hard because on the one hand, you want to stop hurting yourself. On the other hand, all the things that you get from hurting yourself are going to go away. And kind of saying to them, like, I see it. I see how that's a tough call. And I think sometimes helping our patients understand what their values are, and kind of how they can achieve those values, and what kind of goals might help them to get near those. So thinking about those kinds of clinical strategies. And then the patient buy-in piece. I started this whole thing by saying supporting behavior change. So this isn't just about us doing. Folks have to want to change, right? The patients have to want to do something else. And so the first thing I have there is moving beyond self-harm. So for us to kind of invite more of the patient into the room. So not just seeing our patients who self-injure as cutters, as swallowers, kind of helping them to see more of themselves, inviting more of that person into the space with us can kind of decrease their sense of being invisible, right? I have their dehumanization. We know from lots of our patients who self-injure, they dehumanize themselves, right? Like they stop feeling like human and they see their bodies as objects. And so kind of reminding them that they are human, can be helpful. So if we see the person and not just the behavior, that may help them to see themselves as more than just the behavior. And then maybe they can step into a partnership with us. Maybe they can risk trust. Maybe they can risk honesty or authenticity or something, because until they can get there, they're not going to buy into changing because it works. Self-injury is solving some kind of problem for them. And so we need to kind of see them for more than the self-injury and see if we can't get them to move forward, towards being someone else and acting in different ways. So we want to increase focus on working with patients to identify what they want. These don't have to be clinical. So if we're talking with patients about kind of their goals for themselves, those are probably things that have nothing to do with mental health or physical health. But at the same time, often we can't get to the things that we want in our lives unless we're physically and mentally healthy. So our trouble with physical health, our trouble with mental health can block us from getting where we want to get. And so reminding patients of that, right? That I know that you want to get out of here. I know that that's goal number one for you. And how is this behavior possibly hindering that for you? And so kind of thinking about that. Improving their quality of life. I try to spend time talking to patients about when they have been happy, when they have felt success or pride, even if just in an instant. Like what has that been like for you, and how do we get you back there? Because that feels good. It feels good to feel healthy. And so when's the last time you felt healthy, and how can we kind of try to recapture that for you? Again, the removing barriers piece. So just kind of how are you getting in your own way? And how can I help you kind of move some of those things out of the way? Staying positive. So rather than focusing on the negative, focusing how the patient has grown, or how the patient has changed, or what little steps they've taken. I have used this example many times because it's a true one, and I think that it exemplifies. I had a female patient at a maximum security facility, and she was hurting herself like over 100 times a year. And we worked really hard, and we were tracking her self-injury, and she had, in a time that we were working together, she'd reduced and she'd hurt herself 50 times. That's half as much. Now, that's still like on average a self-injuries event every week of a year, every week. And yet it was half as much as she had been. And I will tell you, they also became much less severe in their kind of in the wounding she was doing. That's humongous, like huge. And so we needed to celebrate that fact. We need to celebrate the half, right? She didn't make it go away. But we had to focus on the positive. And then again, focusing on the movement, approximations of you came so close to, you almost did it, right? You held out for longer than you normally do, whatever it is, kind of helping people focus on those kind of approximations of change. And then this is one of, I think, the strongest things for me that feels rewarding and avoids me feeling burnt out, but also for our patients, which is just, oh, well, like, yeah, you tripped and fell. Oh, well, I'm not perfect. You are not perfect. Lapses are going to occur. For us as clinicians, accepting the things we cannot change, right? I cannot force someone else to change. I can support them in making that change. I cannot make them change. And so taking a deep breath and letting it go when I cannot change something. As I said before, being transparent and genuine with patients is huge. And so when patients engage in self-injury, I think about folks who, we as systems often, we set up like so many roadblocks, right? We think we're going to take this person out of the housing unit. We're going to put them in a sterile, suicide resistant location. We're going to give them one of those smocks. We're going to give them one of those mats. They're not going to have any sharps. We're going to feed them with those, corn made utensils, right? We do all kinds of things to keep them from sharp objects, and somehow they manage to cut themselves because the porter on the unit or somebody left something in the right, and expressing disappointment for them. I am so sorry that someone else made it easy for you to cut yourself, because we were working really hard for that not to happen, right? So kind of being clear and putting it back on the patient. Sure, yes, someone else did something that they shouldn't have, and you got your hands on a weapon, but you made that call, like you still hurt yourself. And that makes me sad for you because we've been working really hard. And so I think being clear with them about the disappointments when choices do get made, rather than scrambling around and trying to figure out who brought the pen and what. I don't know that that's, I mean, there should be some sort of, just to make sure that we're keeping an eye on it, but I don't know that that needs to be the focus with the patient, right? And they will want to deflect. They will want to say, well, they shouldn't have, okay, agreed. And yet, how come you went there? What's that about? And then also talking with staff, because I think that sometimes lots of these patients are not well liked. They're frustrating to work with. They can be interpersonally challenging because of their own kind of characteristics of their personality, right? Who they are, make them difficult to talk with. And so keep reminding staff that supporting patients we all need to be on the same page of it. Because it's a brittle thing, this change. And so I think I am going to wrap it up. Someone wrote, this feels not that different from being an out of control diabetic. No, I think that's absolutely true, right? Like, don't eat the honey bun. Same idea, right? Like, stop buying bad crap from commissary. I can't help you if you're going to continue to do these things that hurt you, right? And so how do we kind of support them? And I think especially folks who struggle with food as well, right? Shaming them and pointing at them. But if food is comfort, when you make me feel like crap, I'm going to go eat more, right? Like, and so we think we're being helpful, and yet that kind of direct confrontation is probably the least helpful thing that we can do. So absolutely, very similar. So this kind of humble and curious, I think, is also just a helpful slant to take when we're working with things we don't understand. Step number one, taking care of yourself, right? Again, allowing yourself to be human, giving yourself permission to not understand things. And I don't know how to help folks who frustrate me, or it's a behavior I cannot comprehend. So kind of being gentle with yourself, taking care of yourself, remembering to breathe, and just as best you can, remaining open and curious, not thinking you already have the answer, truly interested, like the picture of the dog, like more about that, right? Like, I don't, tell me more. Still not getting it. Like, from a genuinely curious place. How did you get here? How are we here? Those kinds of things. And not shutting it down too soon. You know, I think especially in corrections, right? The patient's like, well, thinking about killing myself. Boom, conversation over. They go on watch. We close it down. Like that we don't, they can go on watch. They can go on watch 7 minutes from now, right? So what? Let's talk about it. So I think lots of times, like staying present and hearing rather than shutting down can be enormously helpful. And then lastly, just remaining humble. I don't have all the answers. I've been doing this work for a really long time and it still puzzles the crap out of me. So staying open to the fact that I don't know, you don't know, we don't know, and I just want to know more, right? And I don't know that I have the answer, but I think that we can figure it out together when I'm working with a patient. So that's what I got. I will stop sharing and see if folks have questions. Not all at once, please.
I'll get it started, okay. So I'm feeling like a self-harmer because I want you to fix this for me, and you didn't fix it just now because after all, it's a complex deal, and I would like the easy fix, please. And I was hoping to get that out of this talk, and damn it. So I guess I'd like to start it off by relating with self-harmers because I want you to be able to fix me, and you're not going to be able to fix me like overnight. And some people don't want to be fixed. I think that's true. But I would also like to say that these are the people that in my practice style that I had the most trouble with because I can't control their behaviors. They're dangerous. They're manipulative. They're not adherent. They don't listen to a damn thing I say, or so it seems. Oh, wait, shut up. Okay, I heard that. Thank you. Anyway, it's hard. These are hard patients for us to deal with because, I mean, after all, we're doctors and we're sort of stuck in that kind of role of I can fix you. I know I can fix you. I'm the surgeon. Well, wait, not really. Anyway, I'm going to shut up, but I think
No,
I
but
think
it's
I've
absolutely
made my
valid, right?
point.
Yep, absolutely. And I think it's enormously frustrating. And I think especially, I mean, I'm not a physical health doctor, but I have heard from physical health doctors, like, what, how is this patient here again? Like, aren't you doing anything, psychologist lady? Because he was just here last week for sticking a pen in, you know where. And why is he back? How did he get a pen? What's wrong with custody? How come he's back in my office? How did he cut himself again? How did he get a razor? How did he get those staples, right? Like it feels so overwhelmingly frustrating to be on the receiving end of these patients time and time and time and time and time again. So I get it. I completely get it.
Hi, Sharon. I actually have a question too. How do you, I think I typed this in directly to Dr. Perini instead of to the group. How do you get custody to understand these concepts? I mean, it's so true. You measure improving. I mean, the distance between incidents, you measure and you applaud that and but just like you just said, I mean, how did this happen? How did you let them do this to themselves again? So how do you get custody on board with this? Because they're important in this.
Yep. I mean, I think it's communication, right? It's open communication. I think that it's informal training as well as formal training. You know, I can think about like is especially like in restricted housing settings, like explaining to custody staff like what we're working on, again with the patient buy-in and in a really respectful way. Like, hey, if we're going to try to do this, I want to talk to the sergeant on the unit to let him know like what we're working on, because I want them to help you too, right? And kind of, and then explain to custody, hey, look, we're trying to get so and so to stop doing this behavior. It would be really helpful if when he's yelling, you go over and ask him what he needs, because often for him, yelling escalates into him banging his head, and we're trying to get him to stop banging his head. So if we can respond when he's yelling, I know it's super frustrating, but it's better than having to take him out and then you guys are on OT because you got to send 2 guys to this. So I think sometimes even illuminating for custody how the self-injury also kind of ruins their day can be helpful. Like what are the benefits for you? Kind of same idea. I empathizing with custody's struggle, but also helping them to see that if and when you can get on board with this, ultimately you can have a better, quieter day. And right, that kind of thing I think can be helpful. And almost always there are 1 or 2 custody staff that like can become your little champions. Like they get it, they're in there with you, they understand it, they wish that they kind of could help support. And so I think that that's helpful. But again, I think it's just being open and transparent with them, because sometimes, especially on the mental health side, like they see us as like too soft and, you know, all of that, and explaining that like there's a reason why I'm doing this, and it's not just because like I'm super nice and naive, right? Like there's a reason I'm doing this, and if you can explain it to them, and some won't hear you, some won't hear you at all, and that's why the oh well thing is enormously helpful for me. Like there are, right, out of the 100 officers, there's going to be at least 20 who want nothing to do with any of this and are going to continue to do what they've always done because I'm some idiot psychologist who thinks she knows things and she doesn't. Okay, I'm going to let that go because I can't change that either. And so I'm going to focus on the ones who are really helpful in supporting this. Right? I think that those 2 things can work if that's helpful.
Yeah, it's helpful. Thank you.
No problem. Alicia, I see you.
Hi.
Andy.
First of all, I apologize for not being on camera. I was wondering your thoughts, or even the groups too, but on really large systems that have pretty violent environments, sometimes harming yourself is actually safer than being in the current environment. So then when they're on watch, you understand that they don't want to provide information because providing information is also unsafe. And so I really liked what you said about, well, maybe we can decrease the self-harm. Next time they'll just say, well, I'm suicidal, instead of actually harming themselves. But then we're left with long-term suicide watch place lasting 50 days or more. And so I guess that's where we kind of run into issues. Is we're really helping them. We're decreasing their self-injury, maybe even making their identity change into something else besides I'm the best self-harmer in the prison. But then they stay on watch and they feel safe and they want to stay. And then we're stumped.
Yeah. Yes. Ow, is what I have to say to that. I don't know that I have the answer, but I think that in cases like that, what has been helpful for me is data. That if we can, and this is less about the patient and more about the system, because I think what I'm hearing you say is when he gets off of watch, he's in danger, and that's real. And when he's on watch, he's safe, and that's real. And those things those aren't fabricated, right? And so I think possibly, potentially having conversations with the leadership, right, about those things, like saying it out loud. It's safer for this guy to be on watch than it is for him to be out there, right? And if it's more than 1 patient, and like just as best we can, saying those things and making them real and not pretending that they don't exist. And then being perfectly clear from the mental health standpoint, I can't fix your broken prison system, right? I can help patients make different choices, but the truth is it's hard for me to convince this patient that not hurting himself is the way to go because he's safer with us than he is out there in population. And again, I think the hard part, especially right now, is they're struggling too, right? Custody isn't staffed well, and all of the struggles that they're going through. But I think similar to what I'm talking about with the patient, kind of partnering with custody to say, how do we fix this problem? Because it's not okay. And putting a voice to it and saying it out loud, I think is step number one. I don't know what it will change. And then for patients, the other thing to talk about with patients is, yes, there are noxious situations, and physical danger is a really hard one. But I think kind of helping the patient to see that they are strong enough to handle fear and anxiety. Again, the violence thing is hard, but for some of our patients, it is fear and anxiety, and I don't want to have it, and I don't want to feel that way. So I want to run from it, and kind of bolstering their skill set to kind of be resilient in the face of things that make them uncomfortable. Because some of it's real and some of it might feel overblown too, right? Both things can be true. I know that's not helpful, but it's the only thing I can think of is just kind of going at it system wide.
It's definitely helpful. The continuing to gather data is what we'll do. So thank you. That answer was very helpful.
Oh, good. Okay. Thank you.
Another thought to add to that, Sharon, to Alicia's question is, and you kind of said it, and maybe I'm just saying it a different way, is one of the cool things about correctional healthcare is kind of negotiating creative solutions. And so, maybe putting the person on watch is much better than what they were doing, but it costs us a lot in personnel power, time and effort, because watch is always, I have to have an officer sitting in front of the thing, 20, and being creative and saying, all right, let's not be stuck in it has to be watch or it has to be this. Can we create something for this person that's somewhere in between? We'll call it watch, but I'm going to write something that relieves your officer of the necessity of being there all the time, or every 15 minutes or whatever, so that it solves our problem. But we just have to be creative, and we have to call it something else.
Right. Absolutely. Or come up with a different way to kind of manage him. Maybe not on watch. Maybe he's out in pop, but we check in on him every 15 minutes or something. Right. Absolutely. I like it. Thanks, Mark. Fritz. I think that you're still muted. So
yeah, thanks.
Perfect.
I'm sorry. Thanks for your
No
really excellent talk. We up in Maine, which is full of practical folks. The mental health folks and some of us medical people and the correctional officers, the two in particular who run segregated housing, have teamed up to respond to these issues together. And I think it's had it's reduced violence and self-injury by about 60%, 60% over the past 6 months.
Nice.
And a lot of it is standing and listening, as you said, instead of knock it off, we're going to cuff you up and put you in the corner, blah, blah, blah.
Absolutely. And
really
thank you, because
wonderful.
Absolutely. I think that that's an important thing that you said that I did not say, which is those places that do those multidisciplinary crisis intervention teams where there's a medical staff, there's a mental health staff, and there's a custody staff, and they're responding to patients in crisis. Because lots of times it is a custody thing, and I'm useless about a custody thing. I can't move a house. I don't have a key, right? And so having custody, or it's a medical, right? I've been waiting forever to go to my specialist appointment, and I'm going to hurt myself, so you'll have to send me out. And having the folks who can hear that and manage any of those concerns right then and there, and not having to, oh, I'll call them tomorrow or whatever the case may be. So I like it. I think that that's a really important thing. Thank you for reminding us all that when we can have everybody around, it kind of helps deflect growing issues. Thank you.
And thank you again for such a very good and articulate talk.
Oh, thank you. And I'm a New Englander as well, by the way. I'm a Rhode Islander originally.
Oh, I
As is Mike.
I used to be the medical director for state of Rhode Island.
Nice.
Our DOC back in the day.
Nice.
We have a
Anybody else?
question. We have a question
Okay.
in the so and I can validate this. I've even been party to being part of outside pressure on others to solve a big problem within the building. Now, what are you doing? What can we do? How can we help? Etc. And so there's a question in the chat about the scrutiny that mental health and medical people fall under when, because of these kinds of patients that we're not able to control. It impacts on everyone, and what can we do about that? And I think I know some of the answers, but go ahead.
Yeah.
If you've got
I mean,
anything.
yeah, absolutely. And I see there's another question too about housing environment, so I'll try to get there. So sure, I mean, the truth is anyone can sue you at any time for anything, right? Like, so let's start there. But I think our best defense against that is what we're talking about here. So that you have a viable, reasonable treatment plan, that you are working with a multidisciplinary team to address the behavior, right? That you have put together a supportive treatment to assist this patient in making change. And that if and when someone comes and says, how come he's still doing it? You can say, well, we've been working on these things and here are the challenges that we face. I mean, I think it goes back to kind of the issues that we were talking about before, that the best that I can do as a treatment provider is to help this person make different decisions. I cannot change their decision making. And just being clear about that. I think being haphazard, not having decent treatment planning, not working with patients around contingency management. So, you know, things like safety planning, right? Having a document for the patient that says when X, I'm going to do Y. When I feel this way, I'm going to do this. And having all of those things documented and clear, it's not going to protect you. If somebody wants to sue you, they're going to sue you. But I think having that, like anything else, and I saw there was a question about kind of evidence-based or group therapy. Absolutely, right? There are interventions that help to work. There are interventions that work to help people reduce self-injury. I mean, dialectical behavior therapy comes to mind. There are other interventions that we can use. So when I was talking to you before about kind of the antecedent behavior consequence, there's a whole research around doing functional assessment, understanding what drives the behavior, what supports the behavior in the present, kind of working to reduce reinforcement, all of those things. And so if you don't know those things, and your system has self-injury, I highly encourage you. There are behavioral specialists out there. There are folks that you can get to help consult that can come in and help you kind of build those plans or train your team in building those plans. Because there is research out there about how to help people change these behaviors. We're not like just making it up. And so I think the same way that we talk about medical care, right? Like you're going to use with your patients the treatments that you know have been proven to change the things that you want to change. And so I would say kind of go for that. And again, I don't know that it's going to protect. And it's frustrating, right? Because I think, again, I mean, from a parallel process standpoint, right? The patient is dysregulated. We become dysregulated. The entities that monitor us become dysregulated, right? Like we want this thing to stop and we're all just kind of circling around each other. So taking a deep breath and just saying like, okay, I'm doing the best I can over here. And here's the evidence I have in the healthcare record. Here's the evidence I have through training the staff, right? We're doing the best we can over here. So hopefully that's helpful. And I'm seeing this is from Zach, how might you empower a client to take ownership of harm reduction while an environment like restricted housing where you essentially controlling their entire environment? I mean, yes and no, right? One could argue from an existential standpoint, right, that all of us are kind of in a controlled environment. We just have degrees of freedom, right? And so I think, you know, the person's life is still their life. Their thoughts and feelings are still their thoughts and feelings, all of those things. And so you can empower them to own the things that they do have control over, right? I'm a 5-foot tall person. I'm never reaching something on a top shelf. I can wish for that every day of my life. It's never going to happen. And I don't mean to like make their experience insignificant. I'm not saying that, but I'm just saying there are things that are unchangeable. So we accept the things we cannot change. And what can we change? What can I help you move toward? How can you have a better day in that tiny little awful place, right? Like, and so I think it's those kinds of things, helping them to identify where they can see the goods, where they can see the positives, can be helpful and hopefully empowering them to see that they do have choice in how they choose to see the day even. And being genuine about it, not just to kind of like soothe and make them feel better, but genuinely meaning it, that I think can be enormously helpful around helping them. Anyone else? Because I'm looking at the time and I want to be mindful of that for folks.
Yeah, we're 5 minutes over, and that's awesome because I think it's been a useful discussion. Does somebody have anything else to add that's important? I have put my email address in the chat room. If anybody wants to contact me with ideas about the program, ideas about this program in particular, or whatever going forward, and look for gender dysphoria next month. I hope most of you will attend. And on behalf of the ACCP, Sharon, oh my God, and everyone in this room, thank you so much. It's been so refreshing to be with you, even remotely this way, for the last hour. So thank you very much personally,
Wonderful, thank you.
and for the organization.
Has it really been an hour?
It has,
See,
in
you were
fact,
gonna
an
leave
hour
and
and 5
everything.
minutes. An hour and 5 minutes.
Thank you, Mike, and thank you, everyone. And I commend you on doing this because I think it's really important. So thank you all. And I hope to see some of you down the road.
Thanks. Take care, Sharon, and thanks to
You too.
everybody for attending.